This is a case of stomach lymphoma, during which we'll go through how we simulate as well as how we contour and plan. A 52-year-old man presenting with a bulky diffuse large B-cell lymphoma of the stomach, 12 centimeter in diameter, received 6 cycles of R-CHOP and achieved a metabolic complete remission. And now he's presenting for consolidation using ISRT to a total dose of 30 gray. This is the PET scan that showed the disease originally, as well as the CT thickening that you can see here in the stomach. That's how we simulate. The patient is in a supine position. We would like an empty stomach more than 6 hours. Although whenever you say empty stomach NPO, not necessarily it applies the same to everyone. There are patients who are diabetic. There are patients who are mouth breathers. So therefore, attention has to be paid to these particular patients. So whenever you do the CT sim, please check the stomach to see if it is completely empty. We put the arms up here again, not necessarily because we are going to use lateral beams, but to expose that area in the abdomen for later on planning and uh, to be easy set up on daily basis. We are going to use a deep inspiration breath hold, and I will go through the details of how we benefit from the deep inspiration breath hold in this case. So these axial images which show us how we contour the area of interest where the CTV is the red, and as you can see, we include the whole stomach. We do not go to the perigastric area because once we include the stomach, that would mean we already included the perigastric area. As you can see here, to go from the CTV to the PTV, this is a relatively small planning tumor volume. And the reason we can do that because we are using the deep inspiration breath hold. So this will allow you to keep your PTV small and not to have to take into consideration the major movement that happens to the stomach because it sits just below the diaphragm. Another tip while we are putting our PTV is to shy away from including the heart in the PTV because eventually when you're planning, invariably a dose will end up covering here at least 90% of your stomach. So there is no need in your PTV to include the heart. This is a coronal view that shows exactly what I just explained. Again, the CTV here and then the PTV that shies away from the stomach. As you can see here that with the breath hold, what you can end up doing is creating some sort of a gap between the stomach and the heart that you do not uh, uh, end up having if you do not use a breath hold. And also breath hold is very helpful even if you have a paralysis of the diaphragm, as you can see on the right side of this particular patient. A third important benefit from the breath hold is that the kidneys that moves in and out into your field, actually they stay in the same position. So whenever you report on the kidneys a certain mean dose, that will be a true one because they are not moving in and out into your field. This is how we plan. We try, as you can see, to choose the fields based on where the stomach is located. Stomach is one of those organs that moves a lot, has a different shape based on different shape between different patients. Therefore, when you plan the IMRT angles, you have to have some forward thinking in how to choose these angles. We are aware of the kidneys, and again, because the dose that we use in lymphoma is half of the dose or sometimes less than doses that are used in other GI malignancies, we make sure that the kidneys get a relatively appropriate dose to the overall dose we're using here. As you can see, it is achievable to aim for a 5 gray to be off most of the kidneys. We do the same thing with the spleen. because whenever you include the spleen, even in a low dose of radiation, more than 9 gray, you end up with a lymphopenia. And in patients with lymphoma, and when you give radiation, you want to avoid lymphopenia. These are different views of the critical structures that we try to avoid. And again, as you can see here, this is the 5 gray and this is the 10 gray, and we're trying to avoid a big portion of the heart to get that dose. Same thing with the kidneys, spleen, and liver. You can see here in the coronal and sagittal section how your 5 gray, which is the light purple, avoid the critical organs. As you can see here, I'm more concentrating on talking on how to avoid the critical organs rather on how to target the stomach. We do obviously uh, take pay attention to targeting the stomach, but at the same time, because these patients, they have a high uh, chance of surviving for many years and many decades in certain age group, we make sure that their critical organs are saved from the excess radiation. This is the DVH showing exactly what I wanted you to pay attention to, how we have the liver, the heart, the kidney, etc. Uh, the numbers are excellent, but then at the end of the day, it is very important to look where the dose landed and how much of the dose landed there. Even if I see a 10 gray in the heart, remember that that 10 gray will be divided over the 3 weeks of the course of treatment. So therefore, on daily basis, it's not that the patient is getting 10 gray at 2 gray per fraction. It will be a 10 gray at less than 1 gray per fraction. And that is one of the benefits of using IMRT. So the take-home message, and when treating the stomach, it is important to account for the interfractional motion, including variability in stomach shape on daily basis, breathing, bowel filling change, and to mitigate these changes, making sure that the patient is NPO, modified to a low gas producing diet, use breath hold during treatment, and if possible, utilize daily CT verification to ensure that isodose lines are encompassing the target and avoiding the normal and critical organs. Doses to organs at risks should be minimum, especially since these patients have been exposed to cardiotoxic and nephrotoxic therapy. Moreover, there is a risk that they might need further chemotherapy if relapse occurs. So therefore, avoidance of radiation to the spleen is intended to decrease the risk of lymphopenia, as it has been shown to be important when treating GI malignancies.